the facial feature, we can tell that patient has lost any tooth, right? That is why the facial form is looks normal and it is maintained. However, all the teeth are mobile and weak, but they are still supporting the lips and the cheek. So aesthetically, we should give the same, almost close to the same, right? So in the post-op, you may not see much change in the repose view. Only in the smile it may change, right? So mild lip incompetence is there. Okay, see, mild muscle contraction in the chin. And she may have got some thyroid. And hypo or hypo? Hypo. She is having some scleral exposure here. The philtrum is well prominent. So we should not lose these things, okay, when giving the process. That is a challenge. If you give only 1:1 no, slightly labially, then 1:2, you can achieve these things. So where is the smile? So a better smile photo. Actually, she will be showing more gums. Close repose we have to take for it. Take another profile. She is looking upward actually. Right? How to take? When the opposite wall is very close, this kind of mistakes will happen. This is a difficulty. That is, you have to manually adjust the head and position. So NHP, right? Natural head position. Just read it how to bring the patient to the natural head position. Mild proclination is there. We don't know after surgery patient they expect the same proclination or she wants the tooth to go back. Okay, see, we can see the mild lip incompetence is there. Yes.
Shall I ask to the patient before it's
Yes, yes. You can tell there is a small proclination there, we will correct it. Okay. So that is important. So all gone. Mostly this kind of situation there won't be much bleeding because the gum has shrunk down, it has receded. If the gum is still present here with the boggy swollen, then those kind of situations we see a lot of bleeding. You can see the cementum abraded because of brushing. First recession might have happened because of bone loss and periodontitis, then because of brushing this. We don't know whether there may be history of any out. See, engage tooth loss, you can see this locking. You can see the tooth is locked. See, the cusp is very prominent. They have not treated. Right? You can see there is no attrition. Because the tooth is mobile, they become weak, how they will attrite. So all periocases you can see there is no attrition, the cusp is very good. Like a newly erupted tooth. The occlusal view is not blurred, right? It's not correct. A smile photo, better one. A smile video, right? Only these two things is unplated profile. What is this? Some line? It is. Okay, it is line. You will see that. You can see the severity of bone loss here. looks like as though already there is a good alveoplasty done by the disease, except maybe in the 6. So alveoplasty we may not have to do much, just leveling is enough. In 5 there is bone loss on lingual side also. Basically the lingual cortical plate will be very thick. It won't resorb that much. If it resorbs, that means the disease has been standing for a long time or it is very much aggressive. Here force may be also a problem. This tooth may be getting more force, overload. So already it looks like FP 2 or 3. There is enough space for the prosthetics. So instead of bone reduction, just bone leveling and smoothening we have to do. That's it. So we will be planning 8 implants as usual. From first we will start. You can see comparatively the lingual bone is higher level, the buccal bone is, because the buccal bone is thin, it resorbs much faster than around 13 or 14 we can choose. We will see the 360 degree. If you look closely, here you can see the incisive canal. Okay. Now we will check whether it is incisive canal. So in this technique we can see it. So better to select a shorter length. Lateral incisor. So whenever you are placing implant, the lateral incisor also check the axial. So this is our landmark. This bulge. So during surgery you have to find this bulge and place implant next to it. By mistakenly if you place here, then the implant distribution it will get affected. You will have difficulty in placing this side implant. So here, just next to me like this. There is enough good bone. Bone quality is also good. Mostly around 13. This left lateral incisor area. This discrepancy, labely the bone, cortical bone is high, buccal it is less. So this we have to remove. Right? If you don't remove, then if you place implant like this, buccally these threads will get exposed. Second, let's play more on the left side. So we will see the 360 degree. We will see where is the mental foramen. See the mental foramen, right? It's coming here and anteriorly it is coming as incisive. Just we will check one implant in the second breath. That is where the nerve comes. Here also you can place one implant lingually, close to lingually you can place, right? However, we are not going to place here. You can place in the interdental bone between 5 and 6. Even though mental foramen exits here upper plane, but inside the bone it is down. So that is what the mental nerve exits upwards. From here it goes upwards, right? Inferior nerve only becomes mental nerve, not the reverse, right? Okay. So upwards and buccal. That is the. Do you remember the question?
Yes.
Yes. Upward, buccally, and slightly distally. If you see from this view. The nerve goes like this. Then only it turns into branches. Okay. So here you can place a 10 mm implanted. You can put 10 mm you can place. So whenever you are choosing interdental bone, interradicular, you have to check this. See, here you have to place close to the lingual plate. Now we are going to choose the, we will check the distal root. The distal root is very much distally tilted. So placing along the root is not a good idea, but we can choose the interdental bone. I am getting lingual engagement. 10 mm or long point, whatever it is. We will see the nerve first. So this is the nerve, right? This is the nerve. You can see it clearly. We are keeping the implant just above the knee. We can see the canal. So the canal is very much far away. Anyhow, we are not going to go in this canal direction. We are going to towards the lingual direction, not towards the canal. Whereas if you place like this, then that is also okay. Anyhow, we are going to place close to lingual bone. Okay, left side is right side will check the second premolar where there is more molars, right? Better to avoid this. See, the bone defect is very close to the mental foramen area. So during flap reflection, you should be very careful, or you don't have to reflect very much here. You don't have to expose the mental foramen in this situation, because we have got extraction socket as the guidelines and landmarks. You can open the flap, but no need to expose and see the mental foramen. So here along the mesial root, we are going to place. We are not choosing the interdental area because it is close to this defect area, right? So we are moving towards the mesial root. And we are not choosing the interdental area. Why? Because this interimplant distance will become more. So we are choosing the, and we can tilt it slightly straight. That we can. Very short implant. 10 mm. Okay. Now we can choose. You can choose the interdental bone between 6 and 7. Avoid as much as possible placing on the 7 distal root or mesial root. Access-wise they becomes difficult welding processes. Closeness towards cheek or tongue. Even if you place implant in the interdental bone between 6 and 7, you can give 7. So here we don't know whether which is the nerve, this one or this one. Mostly this one will be the nerve, right? We will check it. There is no nerve. Okay. Yeah, this is the nerve. Right? See how the nerve is shown beautifully here. Anyhow, we are not going to go in this direction, we are going to go in this direction. A short implant. Okay, probably 8 only. Actually, we need only 6, but these two are some additional to prevent any cantilever, to allow for distribution, okay. To withstand if the patient is chewing very high, very heavy food. Right? Out of enthusiasm, they may try everything. So it is a cushion factor against any implant failure or any complication. Placing it. I think.
Patient to cartons.
So if you see here in this axial view, this is the pterygoid, this is the premaxillary area, this is the sinus. You can see that how much the sinus has expanded anterior. Imagine you are placing implant here and placing implant in the pterygoid, see the inter-implant distance. And you can see the compartments in the sinus also on the left side. So the sinus has gone very anteriorly. Okay. This is near the crest. This is near the crest. There is bone, but it is not sufficient. It is only 3 mm height. Now you will see that. So if you see this view, you may get fooled. You may think there is good bone. But actually, it's not so. So this shows the challenge in this situation. This is the second premolar, sinus is closed. First premolar, sinus is closed. Canine also closed. Here somehow the canine, the sinus is respecting the canine and it is stopping here, but here the sinus is not at all respecting and coming anteriorly. So that is the challenge. Sometimes, rarely, even till lateral incisor, the sinus comes. So the more it is coming anterior, the more we are pushed towards anterior region, and inter-implant distance becomes more, and the need for pterygoid comes. Okay, so it is a classic situation where it is a place two pterygoids and anteriorly two implants. If needed, you can place two pterygoids. But now we are going with avoiding pterygoid, avoiding zygoma, placing two pterygoids anteriorly, as many implants as possible. Of course, without violating the inter-implant safe distance. So maximum how many implants we can place? This side 2, this side 2, right? Only 4 implants. Without compromising the inter-implant distance. So this kind of situations, pterygoid becomes very, very crucial and important. They are very much important. So first we will see the pterygoid. You can see the linear height. 96 cm, right? So the sinus has gone till the pterygoid, right? So that is a challenging situation for us. So if you are starting here and if you are going like this, you will be entering the sinus. So you have to tilt like this, right? It is more tilting. So what we are going to do, we are reducing the tilting but moving distal. Now somehow converting the 4 into 3.8 because we are going to be 3.75. Now it looks okay. This looks okay. Now we'll see the buccal in the first section. Okay. Now we are taking it initially. Sorry, immediately. Okay. You can place a decent 3.75, 16 or 18 implant, provided we go at the correct line. If you tilt more distal, right, like this, more distal tilt, your length will come down to 10 mm, right? So our distal tilting should be ideal. Mostly it will be around 45 degrees in this situation. Okay, if you tilt buccally, you will go like this, buccally perfect and come. So towards the midline you have to tilt, distally also correct tilt, all this. Apart from that you have to start from the correct point. If you do all the correct tilting but from more anteriorly, you will be in the sinus. If you do all the tilting correct, but if you start very much distally, you will be going, the pterygoid space, soft tissue. So only if you start from the correct point, you will enter the good bone. So you have to start from the correct way, and both medial and distal angulation also should be correct. So that is why the pterygoid becomes more critical. Anywhere anything can go wrong, and the cases get missed. And the important thing is there is no second opportunity. Once you drill and replace the implant, then second drilling, third drilling, and all, it is not at all possible. Even if you try to do a new drilling, it will mostly go into the same path. It's a very small area. So, pterygoid, you have got only one chance. You cannot do some mistakes and try to correct it later. So, right side. So this is 8. 8 serves as a landmark. You start from this block 8, you have to tilt like this. Then only you can avoid sinus, right? We don't know if it is 8 or 7, it is 7, right? If it is 6, this is 7. So yes, we are going to start from 8. This looks right. The more mesially you go, you are entering the nose. Nose, it's not sinus, it is nose. Because the nasal cavity, actually, nose means this part, nasal cavity, you should tell nasal cavity. So, nasal cavity, you have got two cavities, anterior part and posterior, right? See, here you can see. We think that the nose exists only in the anterior. Nose exists only in the anterior part, but the nasal cavity, it starts from the anterior and it goes till the end of the hard palate. That is why if we go too much into here, patient telling swallowing difficulty. One patient was telling swallowing difficulty. Severely secretion. Then after that we remove the pterygoid, that was it. Okay, very, very rarely it happens. Only one is it happens. Okay, so it's in 360. If you go more distally, what will happen? The length will reduce. It will be like this. Not a good quality bone also. So our drilling should be correct. Even 20 mm you can place, provided you are going in correct. So where you are feeling the drop, it will tell whether you are correct or wrong. If your drop is very much superficial, that means either you are into the sinus or into the space behind the tuberosity. Yes, pterygoid space. Right? Now we will check the other bones. Now we will see the 7 area. This is 7, not at all good. Here this part some bone is there, but it is close to the pterygoid. Okay, the apartments will be hitting this side. So this is 6. So ask the patient whether she has undergone any sinus lift. It looks like some sinus lift has been done. So open. Here the sinus floor is 1600 shows, right? The value. But what is the length? It is 5 mm. Right? It was 5 mm. Is not enough. Or else we can use
Implant company.
yes, we can convert. Yes, we will see.
Those days it becomes flat, you see. Want to disturb the structure of the implant or
Nothing. No, nothing. See here, distal to 5. Maybe some bonus there, right? I think it's okay. 4.2 into 8 mm. Oh, it should 6, right? Okay, we will see. Or else we can do some sinus lift with mallet and place in 8 mm implant. We will see. So then organize the mallet also. Otherwise, we have to convert the 8 mm implant into 6 or 7 mm implant and place it. But we have to place it because the bone is very less. You will see the left side also. Left side is not very much. You can see the bone here. Radio opacity, but in between there is some radio loosened spaces. Mostly it will be bone graft. The bone graft is not packed like properly. It will lead to like this. I don't know. We have to ask the experts who are doing science. It's not good, no? Very. So, in the 5 region, so this is the 5 region. Maybe 4 situation. This is 4, right? 4 is also not good. From 4 we will tilt it. So from the 4, if you tilt also, you are into the sinus. So you have to tilt more, right? Then you are into the some good bone. So you cannot tilt from 4. So start from canal. First check the proper axial canal. Even in axial canal, the sinus has come down. No? So slight 5-degree tilt, we are in good one. Okay. So in the 5, sorry 3. In the 3, you are tilting slightly mesially and you are then only working. Now if you place implant in the canal with mesial tilting, you cannot place implant in the lateral actually. Right, it will become very close. So you have to place implant in the central. If you place implant in the central, then you may enter the canal.
Tilting it distally from the centers.
Yeah, we'll see. See now, this is the canine tip. This is the implant which is coming towards the mesially. Otherwise, we have to place the implant into the canal. That is the only way. So what we have to do is, we have to clear the contents of the canal and place a wide body implant. Okay, and you can see the vomer bone, septum area. You can place a longer implant, right?
We have to remove the also.
We have to clear the contents. Usually we do, no? In all cases we do. You take a big drill and delete first section with a beauty blade. Then take a big drill and use a small curette. Nothing will happen. We have placed, right? Recently for our patient. You can select a longer also. The only thing, palatally, few threads will get exposed, but that is okay because the palatal tissue is thick. It is not an issue. Okay. So now we are going to check the right side. This is 5. There is no bone. Do you need an expert to say that there is no bone? No. Right? In 4 also no bone. In 3 also no bone. Okay, see the sinus, how ruthlessly it has come down, and complicating everything. Now from the canine we will be tilting slightly easily. Now we are saved. Okay. So either you can go like this palatally. If you tilt more palatally, you will be good longer bone. If you go like this, you will be getting shorter bone. So either palatal angulation, or you can do start the drilling here and come. This is also okay. Straight forward is here like this 3.75 into 13 or 16. Okay, give me so much in front here. So mostly around 39. Okay. So totally only 6 implants plus 1 short implant here. Yes, scrutiny only, not asymmetrical. See, all implants are very fragile, they are not very good bone. It tells the story very good. Now, if you see here, from the canine till the pterygoid, see the distance, inter-implant distance. From this canine till the implant distance. If some bone, short bone is there, you can avoid this. Otherwise, you have to place implant in the zygoma. Now we will check whether we can possibly some short implant. We will see. It is only a 5 mm. But the bone quality is good. 700, 800, 8,000. So we will place one short implant also. But we should not get very high hope on those implants. It is better we tell the patient before itself. Or after surgery you can tell. We have placed in between 2 very short implants, they are just additional implants. If it becomes loose, we may have to remove during charlation itself. Right? We don't know, because when you put the scan body and removing it, it may come out. So our main plan is 5 implants. These 2 are just additional. They are replacing the zygoma in essence. Right? They are in the position where zygoma is supposed to be.
You want to do sinus if you replace the implants or
Both sides. We'll see. We're doing surgery, we'll see whether we are doing any